Hello, my name is Caroline Ryan, and I am the Care Transitions Lead for the Administration for Community Living. The following interview is an excerpt from a recent ACL Care Transitions Peer Hour. Each Peer Hour features an interview with representatives from care transition programs in the field. These interviews focus on strategies that your colleagues are using to successfully build and strengthen transition programs, as well as adapt them during the COVID-19 pandemic to continue to meet increased needs. The goal is to share actionable information and ideas that you can bring back to your own organization. If you have any care transition questions or would like to share your organization's innovation experience, please feel free to contact the ACL Care Transitions mailbox at caretransitions@acl.hhs.gov. That's CARETRANSITIONS at acl.hhs.gov.
Great, thank you so much. So today we're going to hear from the field, and we have three panelists. First, we're going to start with Dana Eaton, who's the Executive Director of the SARCOA Area Agency on Aging, based in Dothan, Alabama. Then we will progress to hear from Ginger Weddingfield, who is the Director of Long-Term Care and Healthcare Reform Development and the Integrated Care Network and Gateway to Community Living at the Alabama Medicaid Agency. And then lastly, Nick Nyberg, which is the Programs and Planning Division Chief at the Alabama Department of Senior Services. So you see from this panel, we'll be able to demonstrate how an area agency on aging is working closely with state Medicaid and the State Unit on Aging as a collaborative approach to provide innovation in Alabama. So first up will be Dana Eaton from SARCOA. Welcome.
Thank you, Tim, for that introduction. And yes, we've got a lot of our team members on today from SARCOA and from the state. Our team is very innovative and very energetic, and we're always looking for ways to help our community. So, what did you have questions for me, Tim, or how would you like to do this?
So I think to begin with, I'd like to hear describe the hospital.
Okay, describe the hospital-to-home program. So it's really an enhancement to our community, our gateway to community living, which is a program to transition people out of the nursing home back to the community. So as an enhancement, we're looking to stop people from ever going into the long-term care facility. When they're leaving the hospital, frequently that's their path, is they're going on to the facility. So if we can give them an option to return to home, that's what hospital to home is about. We can transition the people from the hospital back to the home setting for the community-based long-term care, and we put them into the ACT waiver program or even the E&D waiver program, and therefore we're literally diverting them from going to the traditional nursing home placement path.
So that's interesting. Are you sitting at the office kind of waiting for people to come to the office to get onto the waiver? Just how are you finding these people?
Well, you have to be in the hospital, and it's a very short window to get them approved and then transitioned out. So we've narrowed down the group, the population we're looking at right now in the beginning. Those are our full Medicaid beneficiaries. They're already qualified for Medicaid. They also have to have a safe, suitable housing to return to, and they need a willing and able caregiver, and a few other things, criteria, but there's these certain criteria we're looking for. So we have a full-time case manager who is going out and doing outreach with the hospital and pre-screening any individuals that get referred to us. And we are relying on the hospitals primarily to refer patients that look like they are eligible for this program.
So do you have staff going into the hospital, even during the pandemic, to facilitate this diversion activity?
Well, we've got several other programs, and we have a coach that stays in the hospital. She's looking for patients for the programs that she works within in her community care programs. One is the TCM, the Transitional Care Management patients, and others are our health plan patients anytime they're in the facility. Now, we've got 8 hospitals here locally, but we only have one health coach positioned in our largest hospital.
That is an excellent approach. Identifying and enrolling clients right in the hospital. And then you mentioned leveraging one or more waiver programs. So have you worked with the state Medicaid and your state union on aging to have an expedited process for people to get onto waiver, or are they waiting like 90 days, 120 days in the hospital before they can get on?
Well, our normal E&D waiver, the traditional path, it does take up to 45, so sometimes even 60 days to get an individual onto the program. So yes, we've worked with the State Unit on Aging and Alabama Medicaid to have an expedited process for these individuals leaving the hospital, because there is a very short window. They're discharging. They can't sit around and wait for 45 or 90 days in the hospital. So it's usually 2 to 3 days is what we have to work with when they're leaving the hospital.
Oh, that is tremendous. Tremendous innovation. 2 to 3 days, you're able to get them approved for waiver and facilitate the transition, and you have someone embedded at the hospital that's screening and identifying those persons for enrollment that's doing the outreach. Is that correct?
Now, not in all the hospitals, the others, and just in that one major hospital, but they've been responsible for most of our discharges so far, or most of our referrals. But we have had several in the other 7 hospitals as well. But yeah, it's just more efficient to have the one person, and she's looking for potential enrollees into 3 programs here.
Great. Now, to the finances, once that person is able to convert onto a waiver slot, does your agency provide ongoing case management, and is that a potential revenue source to your agency as well?
Yes, we do receive a PMPM, and if that person is transitioning into our region or into our waiver program, yes, we would receive that. We have had an instance where we had one discharging to another region with another AAA, and we were able to forward them over to that AAA to do the the home assessment and the local work, and then they would take that individual and they would receive the PMPM.
That is great. So,
possibility, you could be in towns where you have hospitals that discharge to other areas, like in Birmingham, that's our largest medical center here in the state. They're going to be discharging into all different areas, and we have worked with the Children's Hospital there in Birmingham for a potential discharge there.
Wow, that really shows the depth and range of the capability of our network. So I'm remiss in highlighting the fact that some people on the phone may say, well, you were a CCTP, Community Care Transition Program site, so you must have got a big contract from your hospital that extended the program, and that's how you were able to do all this. So can you kind of describe the evolution? Was it, you just got a big contract and that's how this was able to proliferate?
Well, we wish we had gotten a big contract. So we did have a very successful program. Ours ran from 13 to 17. And we did think that we were going to, when it ended, we thought we would begin working with that large local hospital. But at the last minute, they decided they would build it themselves. which, by the way, they haven't built it yet. So let's see. That was in February of 17. So we had to reduce our staff somewhat. Well, most of them transferred within. But we kept a small team so we would actually have something to sell. We made that investment. And then we started reaching out to any possible entity that might benefit from our services. Local hospitals. We even went out of our region. Provider offices, the doctor's clinics. We did a lot of marketing there. We did a lot of pilots with them. We tried it with a few of their patients if they had some patients that had needs, so we could demonstrate what we could do with them. But eventually, by about September, now this is from February to September, we finally landed on one, and we got us a partner out of that work. They're one of the larger provider groups in our city, and we continue to work with them through today. Now, with them, we're doing the CCM and the TCM billing, and we're not making any money on that, but we're generally covering our bills. But the biggest advantage to that is we can now take it to a health plan or someone else, a hospital, and say that we're actually doing the work. It's small. It only really takes one health coach to do that work. But it gave us a foot in the door after CCTP. And so that was we've got 4 contracts now. Did you have something, Tim?
I was just going to acronyms. So you said TCM, that's Transitional Care Management, and Chronic Care Management is CCM. And so those are Medicare billable services. You've contracted with a local physician group, and they are billing Medicare and then contracting with you and paying you for the service. Is that an accurate description?
That's correct. Yep, it is.
And then,
that's what we implemented.
You also said in the last question around once a person converts onto your waiver program, your agency receives revenue for the case management, and you mentioned that revenue model was a PMPM. So that's a per person per month payment model that you receive for the ongoing case management. Is that correct? Great.
So the rest of our story.
Great. As it relates to your hospital program, it sounds like you had your successful CCTP program that ended, but you wouldn't let it die, and you continued to go from place to place until you found something. It sounds like you have a multi-payer approach to sustainability today, where you have multiple revenue streams that's covering someone in the hospital, and now you've added this hospital-to-home component that's targeting dual eligibles that are in the hospital. Can you describe that multi-payer approach that you've taken?
Well, we've got the 4 contracts, and of course 2 of them we really need a presence in the hospital. And by the way, we used to go into the hospital before COVID. Now we have a space in the hospital, but we're no longer allowed to go up on the floors. So we're looking through. They print us a report of just the patients that we're looking for that provider group and for our health plan patients. They filter it out by that way, but. So we're in there, and we're not, the coach that's in the hospital, she is looking for discharges, Medicaid discharges that would be appropriate for the hospital to home, but she's actually paid by the other 2 programs that she's working in. That some of the payment from that provider group contract, and then also from the health plan contract.
So you mentioned the health plan. So I understand that you have a current contract with Blue Cross Blue Shield of Alabama. How long did it take you to secure that that contract, and is that for a Medicare Advantage population?
Well, before CCTP ended, we went to see them in August of 16, and we made a pitch. And I think we came in a little too high with our pricing, but they weren't quite ready to do it. And they came back, they gave us a call in June of 17, which was, what, four months after CCTP ended, and said they wanted to talk, and they wanted to know if we were NCQA accredited. That's the one thing they asked, and they wanted another proposal. So we went back to see them, and about a year later, we started our work with them. So that took about almost 2 years after that first initial contact with them. So, yeah, it started out being more than just the Medicare Advantage population, but this past year, they changed over to just the Medicare population. We also do a PM with them. So when it went from 3 different products that they had down to the Medicare Advantage, we lost a good bit of the population. So they chose to expand it to 18 counties. We were in 9 counties. We're now in 18 counties, and we are contracting with another AAA to do that work.
Excellent. And so your program sounds like it went from nothing to now you have multiple contracts. And I also understand that this, as of late, your most recent change on this Blue Cross Blue Shield contract is that you were required to take risks. That's been something that's been very, very challenging for our network, but I understand your agency's been able to move right into a risk-based contract with them. Is that correct?
They put in 4 quality measures that we had to meet or we would suffer a penalty.
That is excellent. That is excellent.
So we really built our program around planning to lose that money. We don't have to have that money. And that's what I do.
Great. So one thing that I think is also very innovative, you have a person that's embedded in the hospital. They're not going up to the floors, but I guess it sounds like they're in the case management unit, and they have access to the hospital census data, so they're able to, on their own, independently identify persons, but they're serving multiple programs. So do you have multiple supervisors? Are you combining the funding? Just how do you manage that, where you have a person that's serving multiple programs from a financial standpoint?
Well, we do have two of our departments are affected there. The hospital to home is in our home and community department, and the other 2 are in our community care. But we work together on everything we do here. We make referrals back and forth every day. We're always looking for ways to serve the individual, not necessarily the program.
How do these programs interface with your ADRC?
So our ADRC is working with us for the hospital to home. They're specifically, if they get a call for this, they immediately find our hospital to home coach and expedite that. They understand the importance of time in that process, but they fast track it, in other words. They also help our transition coach with information. They do some of the legwork there if they need to find resources or find information for them during this expedited process. And then finally, if we do find individuals there that don't ultimately qualify for the program, and there are those, then they are referred back to our ADRC, and they begin their options counseling and make referrals and make referrals to our waiver program. And we will eventually get to them.
Great. I have one more question for you, Dana. So CMS recently posted a notice of funding available for Money Follows the Person. I noted that Alabama is one of the states listed. Sounds like there's a great partnership happening in the state. Do you intend to work with the Alabama Medicaid Agency to apply for that Money Follows the Person program as part of that?
Well, as a matter of fact, one of the priority areas under that funding was diversion strategies to prevent nursing facility admission. So, yes, we're aware of it. We've already submitted some information to Alabama Medicaid, and we hope that works out.
Excellent. Thank you, Christina. Next, we're going to move on to Ginger Weddingfeld, who is the Director of Long-Term Care and Healthcare Reform Development at Alabama Medicaid. So welcome, Ginger.
Hey, Ginger, this is Helen. I want to check that you're there. Great, we can hear you. I wanted to just make sure we could. So sounds good. Go right ahead, Tim and Ginger.
Great, thank you. So Ginger, Dana spoke about how she's able to leverage the Alabama Medicaid Community Transition Waiver to implement the hospital at home. So can you describe the structure of that waiver program?
Sure. Alabama was not one of the original states that took advantage of Money Follows the Person. I think in 2008, the administration at the time, didn't wish to pursue that. So at the agency, we worked on a waiver program that would kind of serve the same purpose, but we wouldn't necessarily, we wouldn't be participating in Money Follows the Person. So it was created to be a transition waiver to move individuals from the institution to the community. Some of our existing waivers didn't have quite enough support because individuals coming out of the institution, sometimes have a higher clinical need more often than not than individuals that are already in the community. So we needed a waiver program that had just a little bit more services available than our existing waiver programs. So that's how that started, probably in, I want to say 2010, 2009, 2010. And then we did eventually pursue Money Follows the Person in the 2012 opportunity.
So that's excellent. So do I understand that the Alabama Medicaid Community Transition Waiver, the eligibility for that includes persons that are at risk for long-term placement and have not yet gone into a facility?
No, not for this waiver. We do have other waivers like Dana mentioned, the elderly and disabled waiver. Those are for individuals that are already in the community, and then they can start on that waiver. We do have a small caveat in the transition waiver that will allow somebody to transition from a different HCBS waiver program if a nursing home admission is imminent. So it's just, it's few and far between that we have that happen. We like to reserve the slots on the transition program for individuals moving out, but we absolutely evaluate anybody for the most appropriate waiver.
Great. A common question that we receive is there really a net savings to the Medicaid program when we are able to divert a person from a long-term nursing home stay into a community program? Does that really represent a net cost savings to the Medicaid program, in your opinion?
Absolutely. I mean, the numbers speak for themselves. I mean, even this transition population that has a little bit higher clinical need than some of our other waiver populations, it averages about $75 a day to take care of that individual. Our average nursing home per diem is right at $200 a day. So, we're saving $125 per day, over $45,000 a year, just roughly.
Oh, that is excellent. So this net cost savings that you described, when Dana mentioned that person that converts onto a waiver, that they then move on and they continue to provide case management and they receive a per member per month payment. Does that net savings that you've identified, does it include the cost of case management that's paid to the Area Agency on Aging?
Yes, that daily figure includes the interaction related to case management.
Oh, that's excellent. So with the ability to implement a diversion model, we found across the country that some of the difficulties in getting people out of nursing facilities is that if they've been in a facility for an extended time, often they've lost their housing. And so housing becomes a critical factor. So their approach to support diversion activities so that persons don't lose their housing seems really, really innovative. Was that part of the thinking as you all developed this waiver program?
So hospitals, moving the hospital transitions out is a relatively new concept. The original premise for the waiver would have been, nursing home individuals moving out. And it actually originally did have a stay requirement before we could move somebody out. But we amended the waiver and removed the stay requirement. So now, as long as you've been in the institution, you have the opportunity to qualify for the waiver and move home. Because we were discovering that you are correct that the longer you stay in the institution, whether it's hospital or nursing facility, you run the risk of, losing not only your housing, but your support system. Your family members, your caregivers move on. They may, get involved in something else, and then they're not available for you anymore. So the making somebody wait, if you will, to meet a stay requirement was a struggle and was having a negative impact on who we could move out.
So that's great. So it was actually a policy change where you all removed that requirement so that you could address these issues and assist people with getting placed into the community more frequently.
Right, and along those lines, Money Files the Person has a stay requirement. So any referral we get from the hospital or the nursing home, we treat those individuals equally regardless of their stay. And once we move them out, if they've met the stay requirement, then we get the enhanced FMAP. If they haven't, they get regular FMAP. We certainly aren't going to turn down a referral because they haven't met the stay requirement.
Great. That is excellent to hear. So one thing that's very notable is that Alabama was the first state in the country where every AAA in the state successfully achieved NCQA accreditation for long-term services and supports case management. And we know that you advocated for the funding to repurpose no wrongdoer funding to support that initiative. Have you seen that demonstrated return on your investment where you've had a change in the delivery of waiver case management through your investment?
It's not specific to waiver case management. I think it's, overall functioning of the AAA in general. I mean, now they have a standard set of policies and procedures. They have a standard set of expectations. They have a standard set of quality reports that are expected of them. So I've been really pleased with the consistency and be able to have the same expectations for each region because it hasn't always been like that. So along those lines, the waiver case management, it has its own rules related to the waiver document. So the NCQA accreditation was a great option, I feel like.
Excellent. I just want to highlight the fact that you also had the forethought to invest in a technology platform so all the AAAs in the state are all working on the same technology platform to deliver an NCQA accredited case management model. So that also improves consistency from market to market since everyone is on one unified technology platform. So that is very innovative. Next, it's well documented that many persons that are potentially eligible for spin down could be enrolled onto a waiver program, but they need to go through that process. So is it beneficial to Medicaid to also begin looking at the spin down population to avoid unnecessary hospital nursing home placement for waiver?
Speaking from my waiver bubble, I believe that's a good option, but understand that if we were to modify our financial eligibility, that has larger implications than just my waiver population. So for me personally, in my population, I would be supportive of it, but that would be an agency decision, and it's not currently something we're looking at right now.
Great. Thank you. So next, we're going to move to Nick Nyberg at the Alabama Department of Senior Services to hear from him. Welcome, Nick.
Hey, Tim.
Hi.
Glad to be with you.
Great. So we've heard the great work that's happening on the ground and the collaboration with Medicaid. And so we want to hear from the state unit. So from a policy perspective, Ginger really highlighted the clear financial benefit to the Alabama taxpayer and the Medicaid program to increase activities to divert persons from long-term nursing home to community. I think Ginger said the difference between $75 per month to $200 per month. So that is definitely significant. And so as there's increased consumer demand for nursing home diversion, has the State Unit on Aging considered the Medicaid claiming to support that? And are there other Medicaid claiming efforts that you're doing to enable people to get onto waiver in the state?
Well, it's a great question. As you know, ADS, or the Alabama Department of Senior Services, that we call ADSS, through the ADRCs to the state, we've been utilizing what I know as Medicaid administrative claiming for several years for the sustainability of the ADRC system here in Alabama. And, I believe that we have a very important role in regards to helping seniors and people with disabilities stay home. I believe that we certainly have a workable, unique system set up for seniors and the senior citizens and people with disabilities in Alabama seeking to receive the information and assistance they need as to receive the much needed help they require to stay at home and in the communities they reside. Although I'm unable to completely answer the question about the Medicaid administrative claiming, because it's really more about collaboration, more geared toward Alabama Medicaid and maybe even the waiver division in collaboration with the ADRC No Wrong Door program. I can say that as a representative with the state unit on aging, that I'm certainly hopeful about future planning and collaboration with our partner Alabama Medicaid regarding hospital transitions and specifically targeting that area. I would always welcome the possibility of further streamlining applicants to receive the assistance they need. It's definitely a worthy goal to obtain. And, I absolutely believe, especially during this unfortunate time of COVID, that hospital transitions are certainly important. And what looks to be, a good opportunity to help those who enter the hospital system, not knowing what's next for them. I would also say that the shifting of application assistance for the ACT waiver, which is our Alabama Community Transition Waiver, or even the ED waiver, Medicaid waiver programs under the umbrella of the ADRC sector, it seems viable, but there again, future collaboration will need to continue to take place in our state. There's certainly a starting point for talks and planning, and it has begun with doing this webinar and other talks even before the webinar. We have great staff in all sectors pertaining to this subject, that I see would come to the table to weigh the possibilities to work more with hospitals in our state for transitions. In Alabama, we've always encouraged hospital partnerships, at least within the realm of ADRCs and outreach and marketing to different entities in the communities, and hospitals is a big part of that. And so we, always encourage hospital partnerships across the state, especially with case managers, discharge planners, because they have a tough job, especially during a time where have more people coming into the hospitals and being admitted, and they need to be able to do a safe discharge and help the people that are going to come out of the hospital, and a lot of times a quick manner. So as we know, people have to be discharged, and simultaneously they may need assistance such as in-home assistance, whether it's through a Medicaid LTSS program or any of Older Americans Act program, meals, medication assistance, whatever that may be. And during this time of COVID, we have encouraged even more so the importance of hospital relationships. And ADSS provided I'd say the Administration for Community Living has provided that bridge somewhat to help through that emergency COVID No Wrong Door grant that we applied for and received back in maybe April or May. But either way, that's maybe some future talks and collaboration and planning for this, Tim.
It's excellent to hear how the State Unit on Aging is collaborating both with Medicaid and with the AAAs to implement these innovative models. So you mentioned Medicaid administrative claiming. How long has Alabama been approved to implement Medicaid administrative claiming?
Well, it's long enough for me to have to go back and look and search, Tim. It was several years, and so I was going back and look. Before my role began here at ADSS, I worked with one of our state's AAAs as the ADRC coordinator for 15 years. I was there for 15 years. Most of my years was spent as an ADRC coordinator there. So, I've been working with the Medicaid process since we were able to start that process, that claiming process, and we started the journey around 2013, which has been about fiscal year 2014. So several years now.
Great. So what recommendations would you have for other state units on aging that may be considering implementing Medicaid administrative claiming in their state?
Well, my first recommendation really would be just do it. And I know that sounds direct and it sounds really general because doing it takes a lot. At the time I was working for one of the AAAs, and now that I'm here as a planning chief at ADSS, I know that it takes a lot more than just doing it, but really asking the right questions and collaborating and coordinating and developing the process, and then training and even more training and then implementation, took place for it to happen. But what a great asset to utilize. I mean, if your ADRC, is working correctly, anyone in your state that comes to the ADRC, whether that's a senior citizen or a caregiver, a person with disability, a veteran, whoever it may be, when they enter that physical door to your ADRC or the telephone door, so to speak, which I know a lot, specifically in the state of Alabama, and I'm sure across the country, we certainly do a whole lot of telephone calls within the ADRC. But, if all that is going correctly through your ADRC, then and all benefits and resources are being utilized for, the screening process for counseling on all the options, then, and that includes Medicaid benefits, Medicaid LTSS programs, any of that. And because of that screening, that Medicaid administrative process can be utilized. Second, I would say training is key, and I know that that's a given. I mean, all this requires a lot of training. But the reason I say that is because even before the Medicaid process came about, in Alabama, we first worked for many months, maybe even to a year plus, working out a software piece that would be a great screening tool for Medicaid programs, LTSS programs, Older Americans Act programs, state funded, local funded, on and on. And then when the Medicaid administrative process came along sometime later after that, we had to plan and collaborate and plan even more to come up with a reimbursement system to be fully functional and to meet the requirements set for by Medicaid. For all of what the ADRCs do to make that process come to fruition. And finally, I would say practice patience and be diligent. It's a big learning curve within the process. Because of the complexities with having a good software piece that has good assessment, a good person-centered assessment that's going to gather all the information, demographic information, and well beyond that. So the complexities involved with trainings on that, and then the trainings to utilize the Medicaid process, and make sure all the bases are being covered in regards to honoring Medicaid's requests to be in compliance, of course, and that's in regards to being reimbursed properly for, full screenings and assistance that's completed within that ADRC process for all the programs and benefits. So that's what I would say.
I think that is excellent encouragement for folks to jump in and just do it, particularly with this pandemic. So it's great that you all seized that resource early on and you're able to leverage it now. I think that's a great segue for us to hear from the foregone expert in Medicaid claiming. We're now going to be joined by Christina Bowen, who's going to provide us some information about Medicaid administrative claiming.
Thanks, Tim. Hi, everyone. So great great segue there into Medicaid administrative claiming. I see a question that came in on the chat. What is Medicaid administrative claiming? And I'm Christina Bowen, and I've been working with ACL for the past 17 years or so, kind of on ADRC development. And through that process, we've been tracking which states have been able to leverage Medicaid administrative claiming to support their ADRC and no wrong door work. And so what Medicaid administrative claiming is, it's basically anything that supports the efficient and effective administration of the Medicaid program. So that's the technical definition. But the things that you're seeing on the screen right now are the types of administrative activities that could be eligible for claiming. So they're called administrative activities because they're not technically Medicaid services that you would see in your state plan, but they're things that support the state plan. So anytime that you're talking with someone about the Medicaid program, explaining what it is and what a state recovery might mean, or whether or not Medicaid makes sense for them, or whether they're in the range for the income requirements, all of that intake and that assistance, if you're helping someone fill out the financial eligibility application. So all of that work is eligible to be reimbursed by Medicaid through Medicaid administrative claiming. Even the work that you're doing in talking with your Medicaid agency about how to streamline access, so this type of program planning, any training that you provide your ADRC staff about Medicaid and what they should be up to speed on. So these are all the activities that could potentially be eligible. And so I'm willing to bet that if you're not capturing Medicaid administrative claiming, that you're probably doing some of these activities that are on this slide here. So it's really important to kind of dig deeply and look at this as a sustainability option, especially when the state budgets are so tight now. You may have more luck going for state funds that are matched with federal funds. So again, and it's not a grant program, so it's a sustainability strategy that we think makes a lot of sense. If you go to the next slide, so back in 2015, I think it was, the ACL worked with CMS and put together this guidance specifically for no wrong door systems. So this screenshot is from the CMS website, and it is a guide that will describe how to set up the infrastructure to claim. And ACL also developed a toolkit to accompany this guide, and that is on the ACL No Wrong Door website. And the toolkit has instructions, but also templates that you can use for your state, a sample work plan that you can download and tailor for your use, and it has information about like sample slide decks you can use with partners to get them on board, cost pool tool, and many other tools that might be helpful to you. But I guess I also want to say that if you want to have a one-on-one conversation about this for your state, we're here to do that as well. And if you go to the next slide, we've got the contact information. So if you want to have a one-on-one conversation, you're welcome to email the No Wrong Door box. We also periodically get the states together to talk, and the next time we have an office hours, as we call it, a Medicaid office hours, is November 17th at 3 p.m. And so that's for state-level staff to talk with one another about how it's going in their state, if they want to enhance claiming, or if they're looking to set up the infrastructure to claim. So we invite state-level staff to join us for that. And then you'll see the link there for the ACL sustainability webpage, and that's a screenshot of the page. We have a map with which states are claiming and which states are in the planning stages. So we'd love to hear from you. We think it makes a lot of sense to consider this as a sustainability strategy. So back to you, Tim.
Great. Thank you, Christina. So now that you've heard really a fire hose of information from Alabama, I hope your wheels are turning in your mind as you're really thinking about how the state unit is working with Medicaid, is also supporting the Area Agency on Aging. So the input from Ginger, Nick, and Dana has been so valuable.
Thank you so much for listening today. We appreciate your time. We also want to thank our speakers for sharing their experiences with all of their peers on this Care Transitions Peer Hour. If you have any questions or would like any direct support from our technical assistance team, please reach out to the ACL Care Transitions email at caretransitions@acl.hhs.gov. Thank you.